So Franklin should be able to. Franklin can see it.
How do we log on to this? From Facebook? What's it designate?
It should be under a live event. You're on live now. Put a video. Click live event.
Here it is.
Nice. You're on live.
So we're good to go.
Good job. Well done.
We can watch ourselves. Can I watch myself while I'm talking?
Watch yourself.
That's bizarre.
Like a monitor.
But it'll be delayed by 2 seconds.
At least. Thank you, I appreciate it. I think the key is to the needle hotspot in both, right? And try to get the other kid line. Yeah, because if they don't have one, oh, they don't. Good? Come on. Okay, sounds good. All right, thank you, appreciate it.
Well, thank you all for coming. It's 7 o'clock, so I think we should get started, so we're not here too late. I'd like to thank you all for joining us for this colorectal cancer themed seminar. I'd like to also thank the NYSGE and our sponsors, Boston Scientific and US Endoscopy. For those of you who might have come in via this entrance, in order to get CME credit for the seminar, you need to sign in. So just if you want CME credit, make sure you sign in right here on the way out. And with that, I'd like to introduce our first speaker, Dr. Robin Mendelsohn, who is a gastroenterologist at Memorial Sloan Kettering. Before that, she did her residency right here at Weill Cornell. And she'll be speaking on the prevalence of early onset colorectal cancer.
Yeah, I would check those off. Yeah, that's good.
So, thank you. Thanks for having me and for coming on this lovely rainy evening. So I'm going to talk about the prevalence of young onset colorectal cancer. I could probably talk about it for hours, but I'm going to try to get it done in 20 minutes. So I think most of us are familiar with this graph and proud of it, showing that since the 1990s, we've seen this nice decrease in the incidence of colon and rectal cancer in the United States. But I think it's important to be cognizant that this is not consistent worldwide, and in some places we've seen no change in incidence, and in some places we've actually seen an increase in incidence of colorectal cancer. So why this nice decrease in the United States? Well, it's likely multifactorial due to modification of risk factors, better treatment, but the majority has really been attributed to colorectal cancer screening, namely colonoscopy with identification and removal of precancerous polyps. So this is that nice graph of those 50 and over, but in contrast, we've seen this increase in those under 50, and it's increased about 1 to 2% per year since the 1990s, and in total about 67%. This is not unique to the United States, it's being seen worldwide. This has been shown in the UK and Australia, in Northern Europe, and in Southern Europe. And it's also not a new concept. It's actually been published in the literature, mostly the surgical literature, since the late 1990s. They were mostly cohort studies that occurred through the 1990s and the early 2000s. And then in 2012, this letter was written entitled Young Onset Colorectal Cancer, Is It Time to Pay Attention? And they reported on a national cancer database of a large group showing this increase, showing that it was left-sided cancers and that they were presenting at late stages with advanced pathology. So when the question came up, young onset colorectal cancer, is it time to pay attention? I think that's when we all said yes. So when you look at the groups by 10-year age groups, you see that it's increased in all of the decades, but it's actually increased the most in the 20 to 29 group, in our youngest group, and it's increasing almost 4% per year in this young group. And when we look closer at the age-specific trends, I think this is interesting. So you see in those over 50 in our screening group that the incidence has been decreasing, whereas it's been increasing in those under 50. But when you look at the 55 to 59 group compared to the 50 to 54 group, and both of these groups are in our screening group, what you see is that the 55 to 59 group is decreasing, whereas you're starting to see this increase in the 50 to 54 group. And you see it a little bit more closely, better here, where you see colon, and even more so for rectum, this increase in the 50 to 54 group, and a decrease in the 55 to 59 group. And since we think that the adenoma and carcinoma sequence takes about 10 years, the question is something now happening earlier that we're just not capturing? When we look at our patients, this was when we looked back at our group, we looked back at the last 10 years, we've seen about 4,000 young onset patients. The majority present with rectal bleeding, abdominal pain, bloating, or change in bowel habits. So we encourage everyone that when you see a young person with rectal bleeding, that it's not always hemorrhoids, and then if it persists, they should be evaluated. These are left-sided cancers. About 75% are going to be on the left side, mostly sigmoid and rectum. They present at late stages, so the majority are presenting at stage 3 and 4, and they're presenting at later stages than our average onset cohort. And the predictive model shows that this incidence is just going to continue to increase. So this is for colon and this is for rectum. Above the black line is under 50, below is over 50. The blue line is the youngest group, the 20 to 34 group. And as you can see, they're predicting that those under 50 for colon and even more so for rectum are just going to continue to increase. And they predict that based on this by 2030, which is not that far away anymore, the incidence of colorectal cancer in young adults will nearly double. That 10.9% of colon and 22.9% of rectal cancers are going to be in patients younger than our current screening guidelines. So in other words, out of all of our colorectal cancers, 1 in 10 colon and nearly 1 in 4 rectal cancers are going to be in those under 50. These patients, when you look at SEER data, they're showing that younger patients have poorer survival rates. When we look back at our data, and we presented this at ESMO this past year, we actually found that our younger cohort did better than our average onset cohort. We thought at first maybe it's because they are more likely to have left-sided and rectal cancers. And this is Rona Yeager's data, who is one of the GI oncologists that we work closely with. And she showed that right-sided tumors are associated with a worse prognosis. So we thought perhaps that's why our younger patients did better. But when we compared our younger to our average onset, for both left and right, our younger patients actually did better. And when we looked at our younger patients and compared left and right, though the right-sided cancers did do a little bit poorer, this was not statistically significant. So this is something that we're looking into now, why SEER data showing poorer survival. Our hypothesis now is just that SEER data doesn't include treatment, and our patients are all getting treated, so perhaps that's a difference, but something that we're looking into. But these are the overall mortality trends for those under 50. And as you could see, it plateaued off and might even start to be increasing. But when you compare it to those 50 and over, it's clear that something really needs to be done. So the million-dollar question is, why is this happening? So whenever you see a young person with colon or rectal cancer, you just say, oh, they have a family history, it must be genetic. So the majority of these patients are sporadic, with about 10 to 20% having a genetic mutation. And these are our data, and you can see the majority did not have a family history. And a quick note on genetics. So like I said, about 10 to 20% of these patients will have a genetic mutation. But a third of these patients with mutations do not meet criteria for genetic testing. So there's nothing about their family history or their tumor biology that would make you think, oh, they need a genetic workup. And so the take-home point is really that the majority do not have a genetic mutation, but we really can't predict who will have a genetic mutation. So we encourage genetic testing in all young onset patients. Looking at the tumors themselves, these are also data we presented at ESMO, and the tumors appear to be the same, the young and the average onset. They have the same mutation burden. When we looked closer, the young onset were enriched a little bit in P53, and this was statistically significant with a p-value, but when they did the q-value, which accounts for possibly false positives, it was not statistically significant. So this is something we're actively looking into. We know that obesity and diabetes are risk factors for colorectal cancer, and these are increasing in younger people. And when we look at the maps of the obesity and colorectal cancer incidence in those under 50, there are clearly some overlaps, but this is clearly not the entire answer. This was a small study that was published at the end of last year looking at the Nurses' Health Study. They had a small number of cases, so 152 women who developed colorectal cancer under 50, and what they found is that these patients were more likely to have a higher current BMI, a BMI of age 18, and weight gain since early adulthood associated with their young onset colorectal cancer. So there are a lot of people looking into this. Anecdotally, none of our young onset seem to be obese. They seem to all be marathon runners, which is why I keep on saying I'm not going to run a marathon. It doesn't seem to be that obesity is at least the major driving force. And when we look back at our patients, when you look at their BMI, when you combine the overweight and obese group, they were more likely to be overweight and obese. But when we compared them to a national cohort under 50 who did not have cancer, our patients were actually less likely to be overweight and obese, and we excluded anyone who presented with weight loss to try to take that out of the equation. It's a young cohort, so they don't have many comorbidities. When we did look, our patients were more likely to have diabetes, but these numbers are small and something we're continuing to look at. Our patients were less likely to have ever smoked, and less likely to have ever smoked compared to their national cohort without cancer. So again, one of the risk factors that doesn't seem to stand up. Is there something in the environment? So when you look at the maps of those under 50 and over 50, you see that they are different. So perhaps there is something in the environment, and again, something that we're looking into. Lifestyle and diet is a big question. So we are moving less, we're eating more fattening foods, we're drinking more soda and less milk, all something that we're looking into. The hot topic of the microbiome is the answer in the microbiome. So there are data to show that changes in microbiome may be associated with the risk of colorectal cancer. And as we've been giving out antibiotics, like their water, the question is, have we changed their microbiome? And again, this is, we are looking into this as well. We're checking the stool on all of our young onset patients. But the bottom line to the million-dollar question is we don't know why this is happening, and clearly more research is needed. And not only that, what about these patients? So these patients are a different group than our average onset. They have different needs. We're treating them aggressively when they're young. We're hoping that they get to survivorship. We don't know what this means. We don't know how to follow them. So not surprisingly, when you ask, this is for all young cancer patients, when you ask about fertility concerns in women, cancer-related infertility is associated with increasingly emotional distress and decreased quality of life. And actually, some women are willing to trade off survival to maintain fertility. So they forego certain treatments in order to maintain their fertility. Fertility issues are discussed less with men, but when you ask men, they actually would like to be spoken to about it. But there's really a lack of evidence for GI cancer patients. When we look at our cancer therapy, so there is an increased incidence of amenorrhea in premenopausal women who have been treated with these modalities. The chemotherapies that we use can cause ovarian toxicity. Radiation, which we use in our rectal patients, and the majority of these patients are rectal, can cause uterine toxicity. So clearly something that needs to be addressed. So this was a study that was published last year, and it looked at older patients who got traditional treatments for colon cancer. And what they found is that those that were treated with 5-FU-based therapies had an increased incidence of cardiovascular disease and CHF. So the question is, if we're flooding our young patients with these modalities, what is that going to effect be when they hopefully make it to survivorship and beyond? And overtreatment, so these people are young, they want everything done. We throw the kitchen sink at them because we want everything to give them the most hope. But it's actually been shown that we're giving them more intense treatments without matched survival gains. So something we need to be cognizant of while we're treating these patients. They have a lot of psychosocial and physical unmet needs.